So our next topic is skin cancers, and the first of them is malignant melanoma. Now we are going to discuss some points about the differences between benign moles and malignant melanoma. So the first question is when to suspect a malignant melanoma. Remember A, B, C, D, and E. A for asymmetry. If the two halves of the mole look different in shape, then this is a suspicious feature. B for border. So irregular border or irregular edges. C for color. If different shades of color are present, such as brown, black, and pink, and if diameter is more than 6 mm, and if it enlarges, or if it increases in size, that is grow upward, downward, or outward as a flat lesion. So these are suspicious features. If they are present in a mole, then you will suspect a malignant melanoma. You can see in this diagram, A for asymmetry. Both this half and this half, they are asymmetrical. They are not of equal sizes. B for borders. You can see the borders are not smooth. They are irregular. C for color. Black, brown, and pink colors. Different types of colors are present. D for diameter. If diameter is more than 6 centimeters. And E for what does E stand for? E for evolving. If it's growing in size vertically downward in the skin or horizontally, so in whichever direction, if it's growing, then you will suspect malignant melanoma. So a patient with benign mole that does not bleed or interfere with life, what should a GP do if the patient wants his mole removed? So if someone presents to you with a benign mole, you will refer him to a private dermatology clinic, not to plastic surgery, not to NHS, because cosmetic procedures are done in the private clinics and not NHS does not provide any cosmetic surgery processes. Now, which feature of malignant melanoma will show a bad prognosis? So, for suspicious of malignant melanoma, we have 5 points. Now, these are the 5 points. If they are present, you will suspect malignant melanoma. Now, what is the point that you need to remember, which will show a bad prognosis? Remember that the depth of invasion will show a bad prognosis. Diameter more than 6 mm is a feature to suspect malignant melanoma, and it's not a prognostic factor. Depth of invasion is a poor prognostic factor. So diameter more than 6 mm and varying color are suspicious feature, and depth of invasion is an important prognostic factor. So don't forget this point, that the most important prognostic indicator is depth or vertical depth or depth of invasion, which is also known as breast flow thickness. You can see in this diagram, let me show you. These are the different type of melanomas that are shown. You can see that its vertical depth, the depth of this melanoma or the vertical growth is increasing. So this is depth of invasion or vertical growth is an important prognostic factor. You can see a It can be measured in the form of Breslow thickness. So if it up to this point, then it is 0.76 millimeter. And if it's has invaded the whole length of the skin and reached to the subcutaneous tissue, then the length is almost more than 4 mm. So this is known as Breslow thickness. Breslow thickness is basically the measurement of the depth of the melanoma from the surface of the skin to the deepest point of the tumor. So Breslow thickness is the depth of the melanoma from this point to this point, from this point to this point, from this point to this point. So from the surface of the skin to the deepest point of the tumor, this is known as Breslow thickness. And Breslow thickness or vertical growth or depth of invasion, it is an important prognostic factor for malignant melanoma. Melanoma has another type, that is nodular melanoma. They are just like a nodule and they grow very rapidly into the deeper layer of the skin if they are not removed. So in this diagram, you can see though the color of this melanoma, it's black, but the borders are irregular. So there is a suspicious of malignant melanoma. If you see any this kind of a diagram and you see any features such as asymmetry or irregular borders or different colors or diameter more than 6 mm, or if there is, if in the question they mentioned that the mole is growing in size, then you will suspect malignant melanoma and you will refer the patient urgently to a dermatology clinic. So the patient present in GP clinic, then we will refer the patient to dermatology clinic. The treatment of malignant melanoma is surgical excision if it's in early stages, and radiation and palliative care for late stages. The most relevant or the most important prognostic factor is depth of invasion.
So if it is spreading in a horizontal way and not going deep, then it's not of concern.
No, it will still be a concern. It will still need to be removed.
Right.
Because growth in any direction is a suspicious feature for malignant melanoma. Benign mole, they usually don't grow in size.
Right.
Their borders are smooth or their edges are smooth and they are only a single colored. So that's why growth in even in horizontal direction or in vertical direction or in whichever direction, it will raise the suspicion of malignant melanoma. And if the patient presented to you in a GP clinic, then you will refer the patient urgently to a dermatologist. And for the removal of a benign mole, you will refer the patient to a private dermatology clinic. So the next type of skin cancer is basal cell carcinoma. Remember that basal cell carcinoma is the most common type of cancer in the Western world. Basal cell carcinoma is the most common type of cancer in the Western world. Basal cell carcinoma, it usually occur on the face, and the appearance of the lesion or the diagnostic features of basal cell carcinoma is that they form a rodent ulcer or a pearly lesions with rolled margins. Either a rodent ulcer will be given as a feature of basal cell carcinoma. Or ulcerating masses with a central crater or central depression. They are more common on the sun exposed sites, especially head and neck. Basal cell carcinoma and squamous cell carcinoma, they are both common on the sun exposed sites such as head and neck. Basal cell carcinoma is the most common skin cancer, and head and neck are mostly involved. Initially, there is a pearly lesion, and then there is a rodent ulcer formation with an indurated edge and ulcerated center. You can see in this diagram a central ulcer with rolled or raised edges. For example, as given in this brain trainer, a woman has an ulcer on her axilla. She has breast cancer and had a mastectomy and radiotherapy 9 months ago. The lesion is 6 mm and has rolled edges and ulcerated center. So this is an important clincher to make a diagnosis of basal cell carcinoma. Ulcers with rolled edges on the face, on the nose, or even in any area of the body will always be basal cell carcinoma. As in this example, the ulcer was on her axilla and not on the face. So the important thing is that you need to look out for the features of or keywords for basal cell carcinoma. That is rolled edges with a central ulcer. So if there is an ulceration with rolled edges, it will always be a basal cell carcinoma. Either this point, either this key point, or a pearly lesion. The treatment of basal cell carcinoma is
How do you
surgical.
differentiate from molluscum contagious?
Molluscum contagiosum, first of all, molluscum contagiosum is not common on the face. Molluscum contagiosum usually occur on the trunk.
Right.
And there is no ulcer formation in the molluscum contagiosum.
But this one is in the axilla.
Yes, axilla, molluscum contagiosum is also not common on the axilla. And molluscum contagiosum, it is common in HIV patients, immunocompromised patient, and in children. While basal cell carcinoma, it is adult, it is common in the older age people. And in molluscum contagiosum, there will be multiple lesions.
Right.
And there will be no ulcer formation. While basal cell carcinoma usually appear as a single lesion, as in this diagram, a single ulcer with rolled edges or margins.
Yeah, okay.
So in basal cell carcinoma, it's an ulcer, while in molluscum contagiosum, they are usually papules.
Okay.
Unligated papules.
They are pearly as well, isn't it?
Yes, they are pearly as well, but the other features are different.
Right.
That they are papules, and in basal cell carcinoma, there is ulcer. They are common in children, and basal cell carcinoma is common in older people. And basal cell carcinoma usually appear as a single lesion, while molluscum contagiosum will have multiple lesions. Molluscum contagiosum is common in children and immunocompromised patients, while it is common in older age people.
Okay.
So surgical excision or Mohs micrographic surgery. Mohs micrographic surgery, it is usually done in different types of skin cancers. What is Mohs micrographic surgery? In this surgery, a thin layer of cancerous tissue is removed, and then a second thin layer of cancerous tissue is removed, and it is viewed under the microscope. to check if there are any cancer cells are present. More and more layers are removed until there are no cancer cells uh, viewed under a microscope. So it is done in different type of cancers or skin cancers. Squamous cell carcinoma is also common in sun exposed areas. Immunocompromised people, such as following a transplant, uh, there's an increased risk of squamous cell carcinoma. Risk, you need to remember the risk factors for squamous cell carcinoma, that is immunosuppression, and there are two conditions that are a risk factor for squamous cell carcinoma, that is actinic keratosis and Bowen's disease. So excessive exposure to sunlight, actinic keratosis or Bowen's disease, immunosuppression such as post-renal transplant or HIV patient, smoking, or long-standing leg ulcers, or genetic conditions such as xeroderma pigmentosum and oculocutaneous albinism. If any of these risk factors are given in the question, then you will suspect a squamous cell carcinoma of the skin. The treatment is surgical excision, as like was done in basal cell carcinoma. So as we discussed that there are two diseases which are a risk factor for squamous cell carcinoma, that one of them is Bowen's disease and the second one is actinic keratosis. Now, what is a Bowen's disease? Bowen's disease is basically a slow growing red scaly plaque. So it's slow growing because it's a pre-malignant lesion, or it's a precursor to a squamous cell carcinoma or risk factor for squamous cell carcinoma. So remember that a slow growing red scaly plaque. We have only discussed one type of erythema, that is slowly growing up to this point. Now this is a second type of erythema, that is slowly growing. To be more precise, a red scaly plaque that is slowly growing on sun exposed area. This is known as Bowen's disease. This is a pre-malignant lesion. So on biopsy or on histology, there will be dysplasia or carcinoma in situ, which may progress to squamous cell carcinoma. So it's a very dangerous condition because it can lead to squamous cell carcinoma. So it's very important to diagnose it in early stages, so that management options such as 5-fluorouracil or chirotherapy or excision can be done, so that squamous cell carcinoma can be prevented. So a slowly growing red scaly plaque on sun exposed areas, your diagnosis will be Bowen's disease. And the treatment is topical 5-fluorouracil, chirotherapy, and excision. Actinic keratosis is also known as solar keratosis. It is also a pre-malignant skin lesion that can develop into sun exposed areas and can lead to squamous cell carcinoma. Small, crusty, and scaly lesions again are present on sun exposed areas, such as you can see these small crusty lesions. You can see these formation of these crusts on the sun exposed areas in an older adult. They can be pink, red, or brown, or as the same color as the skin. They usually occur on the sun exposed areas, and multiple lesions may be present. So in Bowen's disease, there was a single one red scaly plaque that was slowly growing on the sun exposed areas, while in actinic keratosis, there are multiple crusty lesions on sun exposed areas. So there's only a slight difference between these two. Both of them are a risk factor for squamous cell carcinoma. So it's very important to make the correct diagnosis so that the treatment can be given on time. The initial treatment for actinic keratosis is fluorouracil cream as well. Usually a 2 to 3 week course is done. Initially, with the use of fluorouracil, the skin will become red and inflamed. So topical hydrocortisone is also given after the use of fluorouracil. Topical diclofenac may be used for mild disease. Topical imiquimod can also be used, barotherapy and cautery can also be done. So the treatment options are same for both of them, fluorouracil, barotherapy or cautery. So this was all about malignant and pre-malignant skin lesions. Our next topic and probably the last one in dermatology is, there are few small topics also remaining. So the next topic is Xanthlaesma nigricans. Xanthlaesma nigricans is basically brown or velvety plaques or dark hyperpigmented areas in the neck, axilla or groin. Xanthlaesma nigricans is a feature of, we discussed it in polycystic ovarian syndrome, because in polycystic ovarian syndrome there is insulin resistance, which can lead to fibroblast proliferation and formation of these brown velvety plaques in the neck, axilla or groin, that is known as Xanthlaesma nigricans. There are some other conditions such as diabetes mellitus, because in diabetes mellitus there is insulin resistance. So yes, these two conditions that you can remember that are important, in which there is Xanthlaesma nigricans. Other than these two conditions, gastrointestinal cancer, Cushing disease, hypothyroidism, Prader-Willi syndrome, there are a lot of diseases which has Xanthlaesma nigricans. You just only need to remember one or two, such as diabetes mellitus and polycystic ovarian syndrome. Mongolian blue spot or dermal melanosis, it is basically a bluish discoloration over the base of back and buttocks. They are benign, pigmented, flat, and congenital birthmark. So it is a congenital birthmark. So when a baby is born and if there is bluish discoloration over the base of the back and buttocks, your diagnosis will be dermal melanosis. There is no treatment is usually required for dermal melanosis because it is a self-limited condition and it will fade with time. So if the mother is worried about or concerned about this bluish discoloration of the base of the back and buttock, then you will only reassure the mother and inform her that this spot will fade away with time. Next is Xanthlaesma. Xanthlaesma is yellow plaques on eyelids, as you can see in this diagram. These yellow plaques, this one, and this one. So Xanthlaesma is basically yellow plaques on eyelids. They can occur with or without hyperlipidemia. So hyperlipidemia is an associated feature, and sometimes hyperlipidemia is not present. So if someone present to you with this Xanthlaesma, then you need to check his fasting lipid profile. And if there's hyperlipidemia, then after assessing a cardiovascular risk, after doing cardiovascular risk assessment, you can prescribe him lipid lowering agents. Otherwise, there is no need to do anything. And if patient want to remove, want them to be removed for cosmetic reasons, then again you will refer to a private dermatology clinic. last topic is lipoma. Lipoma is basically benign soft tissue masses of adipocytes. They are soft and rubbery, mobile, painless, and grow very slowly. So soft, mobile, soft, rubbery masses that grow slowly, you will suspect lipoma. Remember that malignant transformation of lipoma to liposarcoma can also occur, but it is very rare. If patient present to you with typical lipomas that are not growing or slowly growing and not interfering with life, then you will reassure the patient. And if there is doubt about that this has converted into liposarcoma, then you will suspect a liposarcoma if the size is more than 5 centimeter, if there's an increase in the size, a sudden increase in the size or a rapid increase in the size, and if it's painful or if it's deep in the nautical location, then you will perform an ultrasound. And if the ultrasound features are suspicious, then you will refer the patient for an MRI and plus surgical removal. For example, a 38-year-old man presents with 2-year history of short swelling over the right scapula. He notices it has a slowly growing in size over the past 6 months. On examination, painless, non-tender 4 centimeter lump over the right scapula. It is not fixed to the underlying structures. There's no erythema, no tenderness. So it's most likely lipoma. And the most appropriate investigation is to do an ultrasound to see if there are any suspicious features of liposarcoma. So one more question is, a 40-year-old woman presents with 1-year history of soft tissue swelling over the right scapula. This is the same question repeated. The last topic is not lipoma but paronychia. So paronychia, what is paronychia? Paronychia is the inflammation of the skin around a finger or toenail. Inflammation of the skin around the finger or toenail is known as paronychia. It is basically an infection that is caused by Staphylococcus aureus. Acute, what are the features of acute paronychia? Paronychia develops rapidly over few hours and usually affects a single nail fold. There will be pain, redness, and swelling around the skin around the nail. For minor infection, topical fusidic acid can be used. For severe infection, again, because the causative organism is Staphylococcus aureus, so oral fluoxetine, or if the person is allergic to fluoxetine, clarithromycin will be used. And if there is abscess formation, then along with antibiotics, surgical drainage is also required. So this was all about paronychia. So our dermatology is finished.